Okay, so as you all know, I'm Nick Morley, EMIM PGY-2 Rising 3. I'm doing a small talk on comparing plaster of Paris versus OrthoGlass, the two options that we have in our ED for immobilization or orthopedic injuries. Um, Basically, comparing and contrasting them. So, as an overview, we're going to be talking about indications and rationale for splinting versus casting, application benefits and downsides of plastered Paris versus orthoglass, a quick rundown of fractures and how you would manage them. And I'm going to need some audience participation on this. Thank you in advance. And complications, what caused what? And we'll talk a bit more about those. And then conclusions. And just as an aside, a lot of the data on a lot of the studies that I looked at for this, it's pretty low quality. Most of it, I would say, is like grade D as an expert opinion only. It's pretty scarce to find stuff directly comparing the outcomes for these two. So, indications for splinting versus casting. Up top, you see something that's good for a splint. Down bottom, you see something that's good for a cast. Splints are for closed, simple, incomplete fractures, sprains, and lacerations over the joint space. Basically, a temporizing measure to get somebody over to ortho to see if they think it actually needs a cast or fracture. Surgery. For casts, they're the gold standard for fracture union treatment. It's preferred for complete fractures, complex fractures, displaced fractures that require reduction, and post-surgical fractures. Basically, the rationale behind it, immobilization in general maintains the reduction for previously displaced fractures. It limits motion at the fracture site to prevent damage as new blood vessels form and osteocytes migrate into the area. And it's also somewhat of a barrier for further trauma to the site. And down below, you have a handy sort of visualization of the healing process as the fracture develops new vasculature and osteocytes migrate into what was previously hematoma. So how long do these things have to stay on? It varies on location, whether it's a splint versus a cast, and if there are any complications over the course of immobilization. 4 to 8 weeks is the average if you don't have any complications, but they may need to be replaced if they're damaged, if there's trauma to the cast, or if they get immersed in water, if they're too large, if they're too small, if the fracture becomes redisplaced, or if it needs repeat examination, if you're concerned for something like compartment syndrome. Very small text, I apologize, but things to point out here. The longest immobilization periods are for scaphoid fractures, which we see quite a few of, and then the lower extremity long bones and vertebral bones. We see quite a few clavicle fractures, surprisingly short union time for that, and then ribs, also quite low, which I was surprised by as well when reading this. And also something to point out that fracture union is longer than the total time for immobilization. You want to get to the point where the bone has healed enough that you don't need to immobilize it yourself anymore. So, talking about plaster of Paris, it's been with us since the early 19th century. It's well known, well liked by ortho in particular. Putting it on requires putting some stockinette and padding longer than the planned splinter cast. Each layer needs to be soaked for about 4 minutes to activate in lukewarm water. In the upper extremities, usually you put on 7 to 10 layers for the plain cast and 12 to 15 for the lower. However, with this in mind, always remember that increased layers leads to increased exothermicity and increased burn risk with plaster. Plaster generally has a higher risk for burns compared to fiberglass. It takes 4 to 8 minutes to set, but it takes quite some time to cure. So particularly for the lower extremity casts and splints, it's not going to be weight bearing for 2 days. And that can be kind of frustrating for patients who, have things to do, need to have places to go. For benefits, basically, it has this wick effect that develops over the course of its setting. It absorbs sweat, blood, and pus as cracks develop in the plaster, which leads to decreased skin maceration as compared to other synthetic casts. It fits the contours of the body better. Molding it is a much more natural and shape-fitting process, so it leads to fewer pressure injuries and is better for large area mobilizations. Over time, it gains strength. Even after the curing period, it develops and becomes lighter. over the next 3 to 6 days. And it's cheap. If it fails, if you have to cut it off, if it develops some pressure injury that requires remolding, it's not expensive to replace it. Downsides, though, it's not resistant to force. That same microcracking process that allows it to become, lighter and stronger, it can not sustain a direct hit. It's not resistant to water. That's why you need to wear a trash bag over it when you get in the shower. It's also radio opaque, so it can lead to X-ray interference when you're trying to assess for, if something has gone wrong with the fracture, if it's become displaced again. You might need to cut it off. It's also heavy for children, the elderly, or somebody who has, trouble moving their limbs generally. This can be an imposition. And the long setting times, which we already spoke about, can be an issue. Long duration immobilizations will likely need repeat replacements, not just one. So injuries, burns, as I said, are more likely because of the increased layers, especially on the lower extremities. Pressure injuries are the classic problem, particularly compartment syndrome, the dreaded side effect that can be really life-threatening for patients. Here, I wanted to point out, this is a thumb spica cast that was put on too tight. And you can see under the stockinette that there was pressure injuries that were developing into a cellulitis here. You can also get contact dermatitis with these. Basically, they can be very itchy and irritating to the skin, which can lead to foreign objects being under the cast. You can also get cast saw burns from trying to remove these. So application, oh, I don't know why that switched. Anyway, OrthoGlass. So OrthoGlass is a pre-padded and pre-layered fiberglass-based option here in the ED. It requires a minimal soak in room temp or cool water. If you do anything higher than that, you're increasing the risk for burn on these. And they come in 2 and 3 and 4-inch sizes for pre-layering, depending on the desired location. It takes 2 to 4 minutes for setting and only an hour for curing. So much faster and much more convenient for the emergency department setting, I would say. It's much more water resistant. Even immersing a OrthoGlass cast or splint in water will, in the immediate, it reduces its strength about 50%, but it can bounce back to about 90-ish% of its initial strength after it dries. They're much more lightweight, so can be very helpful in terms of kids and the elderly. It has improved porosity, leading to improved aeration, which can lead to less skin irritation. As I said, the fast setting and curing times. And overall, I think it's been favored for splints since it came into common practice with pediatric patients with less complex fractures. Some of the downsides, though, the decreased setting time and conformity issues can lead to more pressure injuries. It's much more difficult to mold to the curves of the body, especially in the time that it sets. So you can get some areas where it leads to more pressure than usual over the pressure points at setting areas. So there's also decreased malleability with pressure release interventions. So if a complication develops that you need to bivalve or you need to adjust it, OrthoGlass is not going to be as compliant as Plaster. And it is more expensive, but I will say not by much. It's about like 2.5 times as expensive as compared to Plaster nowadays. So even though it is on paper more expensive, in practice, I think it's not as much. So injuries you can get from this. Burns, of course, from the setting in particular. Pressure injuries, because of their decreased conformity, are more likely with OrthoGlass and fiberglass. Compartment syndrome, also more likely. This is a picture of somebody who had a short leg fiberglass cast that developed. Initially you could see bruising above the cast, which led them to remove it, and then showed the beginnings of compartment syndrome and then a pressure injury down there by the ankle. So something to keep an eye out for. So Let's talk. Let's get some input. I want to know how you would manage these fractures. The one on the left first, I had to point it out because it was such a subtle finding for me. This is a 5-year-old patient tripped and fell onto an outstretched hand. What do you see here? What do you think you would do to immobilize it?
You said 5-year-old, Nick?
Yep,
Looks like a torus fracture or buckle fracture.
that's exactly right. So this is a radial buckle fracture. Ideally, you'd want to do a short arm splint. In my opinion, based on this talk, I would, go for a fiberglass, an OrthoGlass for convenience, since this is a pediatric patient. On the right, though, 15-year-old, similar story, tripped and fell, but had severe pain and can't move their hand as a result. What do you think? What's going on here?
I think it's broke, and it's significant displacement. Likely, syndesmosis could be affected. This is an X-ray that I would definitely want to see proximal as well, another joint to make sure there's not more unstable. And I
For
guess
sure.
all of that being said, this person I would want more significantly immobilized.
Yeah,
So potentially cast. And probably, let's say the elbow wasn't affected, I would probably do a long arm cast or splint to more immobilize the child.
yeah, I agree. This needs to be also, ideally externally reduced, and will likely, if no elbow involvement, need a long arm immobilization, so over the elbow. Moving on, let's go to the left. Let's get our lower extremities in here. This is a toddler, was what was given, and had basically pain along the lower leg. Not sure if it was traumatic or not. Nobody saw the trauma. So basically, for the interest of time, so it's a simple non-displaced tibial fracture. Ideally, you would get an above knee immobilization for this, so a long leg. Ideally, fiberglass, since this is a toddler, in order to allow them to still use the leg to a degree after the wait period is over. Next is another toddler, but this is the femur. This is a complete displaced comminuted fracture of the femoral diaphysis. This is going to be a very complicated case. This needs to be reduced. This likely needs traction, and this will need a hip spica cast. And because this is going to be over such a large area, the hip spica casts are probably going to be plaster. If they're older than 5-year-olds, you would also consider surgical management with intramedullary nailing, but this one was under 5 years old. Okay, so on the right here, what do you see here? Anybody, shout it out. Huh? All right. So this is a complete non-displaced distal tibia and fibula fractures in a 15-year-old. So this is a Salter-Harris 3 fracture here. However, ortho may ask for a CT on this because Salter-Harris 3s and 4s of the ankle can look non-displaced on X-ray, but may be displaced on CAT scan. I would probably do an above knee cast for this if there's no knee involvement, because of the severity of the Salter-Harris class, and probably be fiberglass again for the pediatric patient.
I was going to say too. I'm sorry if you go back. It also looks
Of
like
course.
the fibula, the lateral mal is
Oh
fractured
yeah,
too.
yeah,
So I mean, if it's just the bimal, I mean, still a severe fracture, but then you want to also think about the instability if the
of the
talus is
joint.
affected. The spacing looks okay, but usually you'd want to get stress films or, like you said, a CT and to see if the if it's completely disrupted. But yeah,
Yeah.
but I agree.
That third one is a to-low fracture. It's very common in 15 to 17-year-olds because
Mhm.
the growth plate fuses from the medial or the middle of the bone and goes out medial. So half of the growth plate is fused, but the other half that's broken is not.
Nice. Right. All right, so let's talk some complications. What do you think is going on over here on the left? It's pretty gnarly, right? So this one I wanted to emphasize because of our use of anesthesia in the ED sometimes when we're doing these reductions and then casting. So this is a lady who got a bunionectomy elective in the OR. She received a regional nerve block of the right gastrocnemius and then had a splint applied, a fiberglass splint, and then afterwards developed a third-degree burn as a result of it because she could not feel the pain that this application was doing. So I always want to say, I want to emphasize, be careful with anesthesia when you're putting on splints and casts because of the exothermic reaction. You want your patient to be able to tell you if they're feeling something. So up top in the top right here, this is basically keloid formation after a saw injury from the cast saw of what was probably a short arm cast or splint made of plaster. And down here on the right, as you can see, there is a right leg and a left leg, with the right leg looking much more plump and erythematous than the left. This is a DVT that formed after the placement of a long leg cast. So something that I read that was quite concerning, with lower leg immobilization with cast, basically there was a study done, and it was one small study that showed that something like 20% of patients, regardless of anticoagulation during their stay, with long leg immobilization in ortho, developed a DVT in the affected leg, which was pretty shocking to me. And the end of that study was about 80, so not something to write home about, but still something to be very aware of when you have lower extremity immobilization. Okay, some other ones. This is the pediatric roundup. Over here on the left, you see there's a bit of a pressure injury and some erythema, and the culprit of that is just to the side of it. Basically, this kid had a short arm immobilization and was using a toy tank to itch under the cast and developed a pressure injury when he left the toy tank under there. Then here you have a infant who had lower extremity immobilization. This is what a pressure injury looks like. This is sort of a dusky skin, and then they also had tenderness over that point. If left intervened upon, this limb could have developed compartment syndrome as well. Over here, similar story to the first image. Basically, a child was using a coin to scratch over a long arm cast, and then the coin got left in there, developed into a little bit of a pressure injury. So over on the left here, you can see a cellulitis that developed during a short arm casting. There's the bullae over the focus of the cellulitis, but tracking up the arm. This is important if you're concerned about some sort of infection that you may have to remove the cast in order to fully assess the degree of injury. Here's another cellulitis, short leg splint that developed. It's not really tracking as much, could be confused for a pressure injury, but I think the main complaint for this patient was the smell. So I think that makes you lean more towards cellulitis. Over here on the right, this was a fiberglass long arm splint. This patient had a cerebral palsy, and because they weren't able to, clearly communicate with the care team, they developed a pretty nasty compartment syndrome as seen by the bullae here. And that's something always to keep in mind with patients who are developmentally disabled or otherwise obtunded. They're not going to be able to tell you what they're feeling. And the consequences of that I'll show you not only here, but here as well. This is what compartment syndrome untreated looks like. This is also a 5-year-old patient who had a short leg plaster cast. and develop compartment syndrome. And this is what it looks like after it hasn't been treated. Over on the right, also, I just thought because this was a classic ED complaint, 11-year-old presents saying, "My cast really smells. No pain, nothing." And then they take off the cast, and there's a little marker here, marker cap that he was using to itch. They had to extract that and really debride that area because of the cellulitis that was developing. So, conclusions to take away from this. Plaster of Paris, it's great for moldability. It's great for large area mobilization. I would, use it in otherwise able adults who are able to tolerate the long curing period and the basically the limitations it places on your ability to take care of yourself. So use for long healing fractures, but be aware that there's a higher risk for heat injury and be careful with anesthesia when you're applying this. OrthoGlass, use it for splints. Sorry, use for faster healing fracture. Consider it for kids and the elderly, people who aren't able to take care of themselves as much. And, there's going to be a higher risk of pressure injuries. It's not as moldable as the classic plaster is. And be careful with anesthesia, again, with both of these. That was really my take-home point from this entire process. These are just some excerpts from a paper from '93 when the fiberglass was becoming more prominent. Orthopedic expert consensus was plaster of Paris should be used in all acute fractures where there's significant soft tissue swelling. And significant molding will be required after application of cast, when examination out of the cast will be required after a relatively short interval. Synthetic casting material should be used when it's felt that a plaster cast is likely to fail within the required period of immobilization, providing there's neither significant soft tissue swelling nor a requirement of cast molding. And for cast braces, which is beyond the scope of the ED, when you need to do a sort of interlocking over the joint cast. And then discussion of basically at-risk patient populations that you should consider a plaster casting, or rather fiberglass over plaster. These are my references. Thanks to Drs. Buckridge, Willis, Solger, and Alvin Reyes for your input and help with the talk. That first reference in particular talks a lot about different materials going into the future and different way more detail on the history of both fiberglass and plaster. And I wanted to elicit from all of you, particularly our Penn faculty, what's been your experience? How do you go about choosing your cast, and whether it's splint versus cast and what material you choose? This, for example, is a camel that suffered bilateral femoral fractures and needed long leg casting for both of them.
I do plaster for all my camel injuries.
You too, huh? Me also.
Yeah. Well, you trained me, so. Great presentation, Nick. I think really kind of interesting thing that we don't talk about or think about, but there is an art and kind of thought process to it. And I think it's important to acknowledge that there's cultures of certain places and practices as well. I think we are much more in a plaster type culture in terms of our orthopedists. I generally more complicated, maybe with some molding, some displacement or reduction, or someone I want closer follow-up in a shorter term will do plaster most of the time. And then if it's kind of a quick immobilization, and I'll do the fiberglass pre-made splints.
Yeah, I agree. I find
a quick thing where I'm just slapping it on and getting them out because I don't spend as much time kind of like molding it and thinking about it. That's my general thought process.
Yeah, if you're just gonna put something straight on, then fiberglass is great. But if you're gonna mold it and move it around, then I find that I use plaster because you have more time to get the plaster where you want it.
I think we have to, kind of separate out. I agree. Like if there's going to be a lot of molding, and we use that term a lot, then plaster is definitely the better material for molding. But more often than not, if it needs a lot of molding, we're probably going to have orthopedics involved, and they're going to, and the culture of our orthopedists are to use plaster, and they use a lot more plaster than probably a lot of other places would. I think that's a cultural preference, and so I think that bleeds into us. But most of our splinting you can't. It's hard to mold a splint from to a certain extent. So most of our splinting is going to be straightforward, and that's what you're going to be doing in most of your practice, no matter where you go. So my default is to the fiberglass. It's just a lot easier to deal with. But I agree that if it's a complicated, like you're sitting there and you're pulling on a wrist to reduce a distal radius fracture, you're probably going to want plaster, because you're gonna need to mold that a little bit in order to keep it stable.
I think just boxes fractures are the ones that require the molding, and that's the one that we're supposed to be doing ourselves. So I think that's where we use it the most, using plaster.
All right. Well, thank you. I appreciate it. It's nice to know that there's a different world outside of Kings and Downstate, one where plaster is not king. But someday I'll be able to experience it. But thank you for your input. Thank you for your